Hello everyone, my name is Audrey Duru. I'm the PGY2 Geriatric Pharmacy resident at the Atlanta VA. Today I'll be presenting Telehealth Geriatric Clinical Pharmacy Specialist Consultation, Integrated Management and Polypharmacy Review of Vulnerable Elders. My co-investigators and I have nothing to disclose. The Atlanta VA Geriatric Research Education and Clinical Center, known as GRECC Connect, increases geriatric specialty consultation using telehealth, and the Atlanta VA employed the Integrated Management and Polypharmacy Review of Vulnerable Elders, the IMPROVE model, which is a pharmacist-led medication management project that increases access specifically to geriatric pharmacy specialists in rural areas. Older rural veterans experience challenges with accessing healthcare and have higher rates of potentially inappropriate medication or PIM use. The stars on the map represent the locations of 4 out of 16 community-based outpatient clinics, or CBOCs, that rural veterans have access to. The Atlanta VA has employed several measures to reach this population. Which brings me to the purpose of this project, which was to demonstrate how a structured medication review conducted by the Clinical Pharmacy Specialist, or CPS, could be integrated into the Telehealth Geriatric Consultation Program. The primary endpoint was the number of medications reduced. Some of the secondary endpoints included PIMS reduced, CPS identified barriers to medication adherence, and veteran satisfaction. This was a single-centered prospective cohort quality improvement project conducted between July 2018 and March 2020 at the Atlanta VA. Veterans were included if they were 75 years and older, had 10 or more medications prescribed, or if they were diagnosed with neurocognitive disorder or dementia. They could also be referred by their primary care provider, known as the PCP. They were excluded if they were followed by specialty clinics mentioned on the slide, or if they saw their PCP infrequently within 12 months. Outreach to rural veterans included posters and brochures in waiting rooms. Brochures about the Telegeriatrics Improve program were mailed out to the identified high-risk veterans. After the letters were delivered, veterans were called by a project coordinator to offer and schedule a consult. This step flowchart further breaks down the process. In step 1, the PCP places a consult, where high-risk veterans are recruited for the telegeriatrics visit. Step 2 is where the pharmacist comes in. The pharmacist calls the veteran or caregiver at home to perform a comprehensive medication management visit using the IMPROVE template. Once the visit is completed, the pharmacist moves on to step 3, which is to alert the geriatrician to their recommendations. Then in step 4, the geriatrician will visit with the veteran and caregiver via telehealth from their local CBOC. Finally, in step 5, data collection and the satisfaction survey are completed. During step 2 of the process described on the previous slide, the CPS follows a computerized patient record system generated IMPROVE template. This is to help streamline the comprehensive review. The CPS asks 9 questions to assess for barriers to adherence, which include questions like, "I'm not sure my medications help," or "I am taking too many pills." Furthermore, during step 2's use of the IMPROVE template, the CPS will assess the pharmacy problem list to identify where critical interventions could be made, including assessing for high-risk medications, polypharmacy, and PIMS. This table shows a breakdown of the baseline characteristics. The mean age was 79.4 years old. And via a chart review prior to the CPS call, it was determined that there was an average of 12.6 medications per veteran and 3.4 PIMS per veteran. This table shows the results for the primary and secondary outcomes. For the primary outcome, the number of medications on average was reduced by 2.5 medications per veteran, with 94% of the veterans meeting this outcome. For the secondary outcome, the number of PIMS on average was reduced by about 1 PIM per veteran, with 53% of the veterans meeting this outcome. CPS was able to identify on average 2 barriers to medication adherence, the most common being, "I forgot to take my medications," and "I am not sure why I am taking a medication." And on average, the CPS recommended 3.6 medication changes for the geriatrician to review. It is important to note that all 17 veterans had at least 1 medication recommendation made by the CPS. The Veteran Satisfaction Survey was done about 2 weeks post-CPS call by a project coordinator. Several yes and no questions were asked as shown on the x-axis. The y-axis shows the percentage. It was determined that most all veterans and caregivers found the CPS helpful for understanding medications, but results were split 50-50 for the CPS being helpful on how to take medications. When asked if they would recommend this service to another veteran, 100% said yes. Some questions on the survey required the veteran or caregiver to elaborate. This slide lists some of the responses. Overall, the CPS was deemed to be knowledgeable and an asset to the rural veteran community. In summary, the improved model optimizes geriatric care to rural veterans via use of a multidisciplinary consultation team, which includes a CPS and a geriatrician. Furthermore, the CPS was able to make clinically meaningful reductions in polypharmacy and PIMS, and successfully identified barriers to medication adherence in this older rural veteran population. How can we apply the results of this project to clinical practice? Well, with the previous success of the improved model, hospitals can integrate a CPS as part of the telegeriatrics consultation team. Also, hospitals can gain more patients by expanding recruitment of additional outpatient clinics. It is important to evaluate both the strengths and limitations of this quality improvement project. Some strengths include you have an expert second opinion or a second pair of eyes to evaluate the veterans, and the CPS medication reconciliation definitely saves time for the geriatrician prior to their telegeriatrics consult. Some of the limitations include the telephone visit may not be as accurate as an in-person medication reconciliation. Also, there are several barriers to telehealth, such as technical difficulties with hardware, PCP turnover, and setup delays with limited staff. This brings us to the self-assessment question. Does a structured approach to medication review by a clinical pharmacy specialist reduce polypharmacy in a geriatric telehealth clinic? The answer is yes. The CPS successfully reduced polypharmacy in addition to reducing PIMS, and they also identified many barriers to medication adherence. Furthermore, and most importantly, veterans were satisfied with the CPS call, and they all highly recommended the service to others. I would like to acknowledge Drs. Kemp and Merck for their mentorship during this project. Thank you for listening.